This is the Continue SAM series in a webinar, education webinar during COVID-19 crisis. Today will be about Heal the Healers, healthcare workers, mental health issues during COVID-19 pandemic. We are lucky to have two distinguished speakers with us tonight. The first speaker will be Dr. Dima Abrash, who will be presenting, and then we'll have Dr. Iyad Al-Khouri helping in the moderation later with your questions and answers. Dr. Dima Abrash graduated from Damascus University Medical School in 2006, and she finished pathology residency in 2011. And then she started pathology at Henry Ford Hospital in Michigan. And later she decided to do psychiatry residency, and she did it as Rosalind Franklin University in North Chicago, Illinois, and continued to work there as a residency program associate director. This is since 2017 to present date. She has special interest in integrative psychiatry, women mental health, and physicians' well-being. We are proud to have her as our speaker tonight, and I would like Dr. Abrash to start the presentation.
Hi, thank you. Thank you, Dr. Azra. Just correction, it's Arbash, not Abrash.
Oh, I'm sorry.
It's okay. It happens with me all the time. So, hi everyone. I'm gonna talk today about a subject that recently has been surfacing more and more, and it's about the psychological effect of the pandemic on the healthcare workers and frontliners. In my talk today, I wanted to, first of all, talk in general about what are the effects of pandemics and trauma on healthcare workers, on the population and healthcare workers in general. And then how about this ongoing COVID-19 pandemic effects? Provide some mitigation and coping strategies. It's gonna be a short talk because we wanted to open the chance for discussion after that. So to begin with, it's what's happening now, or in general, respiratory pandemic is considered a global disaster, and it does affect billions of people around the globe, and it's considered a trauma, and it is for us now. It's an ongoing trauma, as much as any other natural disasters such as earthquakes or hurricanes, because it's affecting everyone or almost everyone on the planet. Doesn't mean that it's less of a degree than any other natural disaster trauma. It may be not as acute on many of us, but it is considered a trauma, and it is considered a natural disaster. So usually, I cannot read my slide. Oh, okay. Can you still see my slides?
Yes, we can. If you want to go to the presenter mode, Dr. Arbash would be great.
Okay.
Thank you.
Better? Okay.
That's perfect.
Okay, so in response to these disasters or to trauma in general, the population will show individual and collective reactions, and the reactions will vary from minimum emotional distress to clinical PTSD, depression, or anxiety, and all the spectrum in between. So, just a little bit about the history of trauma and PTSD, because I wanted to stress that what we are going through now is, again, a trauma, and it will have effect on most of us, if not all. And for that, I wanted to put a little bit light on the history of trauma and how is it seen? How was it seen in the in medicine, and how is it seen now? So in general, data show that most people will experience at least one and usually several potential traumas during the normal course of their lives. So bad things happen, basically. In the late 19th century, formal theory models about links between violent or life-threatening events and psychological dysfunction began to emerge. So that was late 19th century. And the initial theories were basically that trauma-related dysfunction is a result from personal weaknesses, and it's not a normal response, or it shouldn't happen in average population. And these reactions and dysfunction continued to be studied till in 1980, the DSM acknowledged post-traumatic stress disorder as a diagnostic category, and it became a legitimate diagnosis. So things changed between reaction to stress being a sign of weakness and it shouldn't happen, to the reaction to stress is something that may happen in degrees, but it may happen. Unfortunately, the general population, and especially professionals, for some reason, a lot of us are still in the level of having this resistance to acknowledge that trauma reaction, and not necessarily PTSD, but effect of trauma on our psychosocial situation and our function may happen, and that's not something that's abnormal or something means that we are weak. The two fundamental approaches to trauma outcome that have thus far dominated in the field are the focus on two things, basically: psychopathology and average level of functioning. So there is a psychologist in the University of Columbia who has a little bit different concept about what are the effects of trauma from traumatic event and what he calls possible traumatic events, and how they affect the population and the individuals in a spectrum on four trajectories rather than just being diagnosed with a disease or diagnosed with a disorder or not diagnosed, depending on scores or number of symptoms that meet or that do not meet the criteria. These four domains are chronic dysfunction, delayed reaction, recovery, and resilience. So the chronic dysfunction is having this somehow lower level of dysfunction that extend sometimes beyond the acute trauma period, and that keep affecting the function of the person, but it does not become very severe that it is diagnosed as PTSD sometimes, but there is a difference in the function between the person and the general population in that situation. And that's something that Bannon and other psychologists talked about, is that during trauma and during big events that affect the general population, comparison is made sometimes with the average functioning person, where it should be made with the average population or with the general population going through that disaster. So, and having similar cultural backgrounds, because these two affect the function and the psychological effect on the person. And the second category is delayed reaction, and that's still somehow controversial between having a delayed reaction as of not presenting with any reaction at the beginning and having the reaction later, months or sometimes years after the trauma. And that has been studied a lot in grief. And the other theories say that it may be rather having a sub-threshold or very minimum trauma stress reaction that later became more severe due to other situations or due to other triggers. And till now it's still controversial, but the basic theory is that sometimes at the trauma or at the event, the symptoms do not appear, but they may appear later, months or years after the event. Recovery is basically going back to the level of function or almost the level of function of that person prior to trauma or prior to the event. And it's usually what happens in most population. Some studies show 2/3 of the people affected by the trauma will have full recovery, if not months, sometimes years after the event. And that's adults only, because the recovery and trauma effect is different between adults and children. So that's adults mainly. And the fourth one is resilience. And that's something that I found interesting, that they had the definition of resilience as follow. In otherwise normal circumstances, people who are exposed to an isolated and potentially highly disruptive event, such as the death of close relative or a violent or life-threatening situation. So they will have a healthy level of psychological and physical functioning, and as well as the capacity of generative experiences and positive emotions. But during the event, so these people have the average response in normal circumstances, but during the event, they will have a mild or low level of psychological symptoms, and that is accepted as resilience. It doesn't mean that they are not resilient or that they are having a disorder. So having a minimum or low level of some stress, sometimes insomnia, showing some anxiety is okay, and it's compatible with having resilience. And these are the four categories and how they affect the normal functioning with time. So time since the event, and the event is the potential traumatic event that can be, according to this study, it can be it can range between natural disaster, death of a loved one, sometimes divorce. So as we can see that the chronic response and the people who have chronic response, sometimes it continue to affect the function, but sometimes there is a delayed reaction. And usually people who go to recovery will have more reaction at the beginning, obviously, and then they will have lower dysfunction later and later. Resilience is having this mild, it's not the normal, it's not nothing, but it's having this mild effect on normal functioning. So there was a study on the healthcare workers who worked during SARS, and how did that affect them? And the study showed that this study and other studies showed that in general, the effect on healthcare workers are a little bit different due to the nature of their responsibilities and the acute contact with disaster victims. Healthcare workers and first responders are at greater risk of developing psychological and emotional symptoms of distress. Earlier studies show that between 25 to 35% of healthcare workers will show symptoms of PTSD or other psychiatric disorders around the time of trauma. The symptoms usually start with anxiety, more dominant in the first 2 weeks of the trauma, then depression and other symptoms will appear later. Insomnia, that is usually the most common complaint, increase in the first weeks between the most exposed personnel, later in others. So the most exposed personnel will have more anxiety, more insomnia at the beginning, usually first 2 weeks, but then after it's the less exposed personnel who will have more anxiety, and then everyone will progress to some type of depression. Everyone who is affected obviously will progress to some type of depression, and then some people will progress to actual diagnosis of psychiatric disorder, and some people will progress toward recovery. So what are the risk factors that have been found to have a risk to develop greater psychological symptoms? The first one is the closer exposure to the victims and the patients. So the closer the person works with the victims, the more they are at risk to develop symptoms. Actually, younger age have been shown to have more risk to develop greater psychological symptoms. And that puts a lot of questions around having a lot of medical students and new residents on the very front lines. I mean, that's out of need, but there should be some caution or some observation and monitoring about them having a greater risk for psychological symptoms. History of mental illness, obviously, and especially depression or anxiety, and negative perceived feelings toward the trauma source. So in our current trauma is the COVID-19. So having negative perceived feelings toward COVID-19, having the feelings that if you work with people with COVID-19, you will be infected, your family will be infected, and having this whole negative bubble about it will obviously be a risk to develop greater psychological symptoms. Poor social and professional support, and more financial and social network loss. So during this pandemic, most of the population is going actually through emotional and social stress. The factors are numerous, but to mention some: health and life and death concerns for self and family, financial and job stability concerns, and the situation is really unpredictable, and there are too many news and too many variation every day, and that will put stress on the population in general. And the new reality of too many people, of social isolation and perception of losing peer and family support. Working from home for many present many challenges for logistics and boundaries. A lot of the boundaries are too vague when you work from home. Sometimes the space itself, that a lot of the people don't have protected space to work from. They don't have a home office. They have to work in a corner where the rest of the family is there, and there is noise, there is the dog, there are the kids, sometimes the spouse. Sometimes the person himself is used to work from a certain environment, especially people who have issues with focus and attention. They are used to work from a special environment or their office, and they cannot, it will take them time to adjust and work from home. And that will play a big role on having to do this. Also, there is a thing that I have been hearing a lot about from physicians and from other healthcare workers is that having the parents present at home will give the illusion of being free and available, not only for the family or for the kids, but for the person himself. And not having this boundary of traveling to work and having to be physically not present at home is putting a lot of pressure, emotional and actual physical pressure on, and time limitation pressure on the workers who have to work from home. So how about healthcare workers? Healthcare workers are actually, they have more specific challenges. They are more exposed to the patients, and that is by itself a risk for more psychological symptoms. And the infection risk, this whole thing with the PPE and being worried about being infected, and who is to use more PPE and who is to use less PPE. That all is happening, and it's happening for most of us, and if not all of us, and that is affecting the way we feel about this pandemic and the way we will react about this pandemic. Actually, what I hear from physician colleagues, and so I do support groups for physicians who are like, these are like free volunteer support groups for physicians who are going through stress due to the pandemic, and some of the issues that they have been facing is duty. Is this duty toward patients versus personal and family safety and priorities? A lot of the physicians are having this dilemma, and it's not because they are unethical or because they don't want to help their patients, but because it's really a dilemma between having to work with less protection and having the risk to infect the family, or just trying to work the minimum where you can work more hours. This is putting a lot of stress on too many healthcare workers. And readiness for possible death, that actually came up a few times. The readiness for possible personal or family or team death, that usually we know that we will all die, but we are not faced with death on a larger scale and on personal and family and sometimes neighbors and team level. So this feeling that my family is not ready, my spouse cannot manage, what if this person, what if my partner, if your partner gets infected, what if I lose them, what's going to happen? What's going to happen to my parents, to my grandparents? This is also a factor. Another factor is supporting own staff and the guilt of inadequacy, sometimes having to let staff go or not being able to be there for staff. A lot of our offices and our work depend on our physical presence and peer support. And a lot of us are now working, if not full-time, part-time from home. And this is lost with the remote work. The work is going on, but we don't have this physical peer support. And we cannot show staff that we are really supportive as we used to do when we were physically present in the same physical space. The survival guilt of healthcare workers who don't consider themselves as frontliners, because now there is this talk about who is the frontliner, who are the frontliners and who are not, and who's exposed and who is not. And sometimes healthcare workers who are less exposed, they have this internal feeling of guilt about not being as exposed as their peers, and not being as, not sacrificing as much as their peers. And that's really like a self-feeling of guilt, and this is a self-perception. And telemedicine by itself have a lot of challenges. and telework in general and telemedicine. The need for control and certainty. This is something that is especially for physicians and healthcare workers, because usually we are used to control our environment, control the situation, or at least know what's going to happen. If we're going to lose a patient or if we see the risk, usually we see it. Usually, in most cases, we have an idea about what's going to happen. Now, most people don't have an idea or they don't have this control. Some symptoms and presentations that we may see are anxiety and worries about the future, guilt and self-doubt about the actions, depressed or sad mood with withdrawal and flattening of affect, excessive anxiety about the infection risk, and insomnia. Physical symptoms may appear such as shortness of breath or physical pain or any other symptom of panic attacks, irritability and anger from things that we didn't used to be irritable or angry about, and disengagement with family and with staff. So early in the pandemic, there was a group of psychiatrists and psychologists who did some type of mental health intervention remotely to the people in Taiwan, to the healthcare workers in Taiwan. And that actually showed that it did help to address this issue early on. And it actually helped mostly the healthcare workers who are showing mild to very moderate symptoms. They benefit the most from these interventions. And these interventions were between like psychological materials or education, peer support, individual support, and it did help with mental health and with physical health. And this show how each one of these factors affected the other one. The dotted line is not significant, but is not statistically significant, and the solid line is that it is statistically significant. So we see that mental health care affected obviously mental health, and that did affect physical health. Exposure did have a negative effect on mental health, and it did not have a lot of effect on being exposed or having or wanting to have mental health care. I want to be protective of the time. I'm not sure. Okay, so in general, as healthcare workers, we do have all these symptoms, we do have all these dilemmas, and we need to face this while still working and facing the actual health risk of the pandemic. There is a tool that I have been using recently. So some of my background is that I work in the VA, and I do a lot of work with veterans who have PTSD, and that what's going on now is very similar to symptoms of PTSD that I see with veterans who were in service or who were in war. It's not as acute, but it's very similar. And this tool or these categories help with how to address the ongoing trauma now. So SAFE, hope, is the S is for see and recognize. So at the beginning, we need to recognize and see that there is something that's going on. Sometimes we don't see it. Sometimes people who are around us see it and give us hints or directly tell us that there is something that is going on. And we need to see it. We need to recognize that this is going on. The other thing that we need to do is to accept that there is a pandemic. There will be psychological stress, and there will be, as I showed you by data, that there will be psychological effects on most of us. So accept the fact that this is happening, and then try to find and explore how is this affecting you personally, because as studies showed that it is the individual response to trauma that will make the later effect, and that will define how we face trauma. So to know that, we need to explore within ourselves on how is this affecting us, what's going on in our environment, what's going on in our emotions, what's going on in our thoughts, and what's going on in our bodies. Sometimes fear or stress or depression comes in physical symptoms, and sometimes we don't connect, or we try not to connect the physical symptoms with the psychological source of these physical symptoms. And that doesn't mean weakness, that doesn't mean that there is something wrong with us. It just means that we are human beings who have mind and body who are related, and this will happen. So try to explore what's going on. Am I feeling pain? Am I feeling discomfort? What am I thinking about? All these symptoms that I mentioned about feeling guilty, feeling unsafe, fear of death, this is happening, and we need to accept that this is happening. The other thing that I found very important is the expectations management. And at this time of the pandemic, with people staying home, and this illusion of having more time in our hands to do more stuff. We need to clean the house, we need to learn a new language, we need to lose weight, we need to be more physically fit because we have more time and we're staying home more. Or if we are working more, we need to treat more patients, we need to take care of everyone, we need to take care of our staff. And that's almost impossible to happen now. We are going through trauma, and we are expected, and we should respond to trauma, because the response will happen. If not now, it will happen later in a way or another. So we need to have a reasonable amount and reasonable level of expectations, and we need to give ourselves permission not to do the things that we think we should do. There is no should now, because this is the first time we go through this. This is the first time the whole nation go through this, and actually no one knows what's going to happen or what's the best management way. So lower level of expectations. The other arm of the tool is the first arm is the emotional arm, how to deal with our stress emotionally. The other arm is the actual function and actual action tool, and that's with H, with help and support, that we do accept help, we do ask for support, and that's okay. And offer help to others when we can. Just offer help, try to help other people, not necessarily within our profession, but any small thing will make the person feel more valuable, and it will help. And then plan. Whatever we are scared or anxious about, we can put a simple plan. It doesn't have to be complicated. It doesn't have to be the perfect plan, but some planning, some writing will help. And then at the end, examine that this is working or not working, what's working and what's not working, and go through the whole cycle again. And these don't happen in a timeline. These happen together. And the more we go through this, the more we will find the areas that we need help with, and then the more we will ask for help. For example, if we feel that it's sleep that's affecting us, then we will ask for help with insomnia. If we find that it's anger, irritability, pain, whatever, we will need to explore and know at first and accept that this is going on.
So Dima, if I just may, something you said got really my attention. You said something about the negative perception of the event or how it's seen. And it got me to think about the the narrative behind any disaster, when it's like a natural disaster, if the narrative is negative and this, we're a victim of some kind, or this is something that happened because of a punishment, or because something bad, that we are bad people and stuff like that, usually that affects people and affect their response. The importance of narrative behind what's happening is really important. The other thing, you mentioned something, you said there is no like textbook on how to handle stress when it's natural disaster like this. But what can people do on a daily basis? You mentioned something about making a plan or identify some emotions and such. But what have you found challenging in even doing those things? You mentioned the survivor's guilt and sometimes the physical. Do people sometimes resort to lashing out at other people in terms of their family, or blaming, or starting to get outbursts of anger, or even drink too much, or smoke too much and stuff like that? I don't know what you've experienced, what people say, and maybe our audience actually can come up with a specific question about what they feel that has not been working, or that has been challenging to them.
Yeah, so actually what's going on now is, on the level of physicians and healthcare workers, is that most people are having this level of somehow some type of withdrawal from what's going on, emotional withdrawal. It's that we are
apathy,
okay.
like apathy, like
Yeah,
we can't do anything.
So things are going okay, and we don't feel that they are okay. And sometimes what happens is we identify with the feeling of guilt, or the feeling of fear, or the feeling of inadequacy, and we don't recognize, or a lot of people don't recognize, that if you feel this fear, it doesn't mean that this is you, or this is gonna last.
And actually, if I may just say, from research on health workers in specific, this tendency for self-blame and stuff seemed to be actually the first reaction in female health workers versus male health workers. Male health workers tend to be more either numb, denial, or even upset, angry, lashing out at family members, or being impatient. But female health workers tend to be more turning into their like, there must be, like, I'm not good enough, and I'm not gonna survive this because I don't have the skills, etc. Someone posed a question, I think. Do you, Fouad?
We have some questions. Okay. Would think healthcare providers are more immune to trauma, since they always deal with sick people and hard situations. Any idea how could that be interpreted? Actually, that's a very good question, because being exposed to trauma does not always mean that we are going through the trauma and we are developing resilience toward this trauma. And even if we are going through the trauma, that doesn't mean that when we go through another trauma or personal trauma, we won't have the effect of that trauma on us, or we won't have the psychological effect. We won't have the emotions that other people will have. We may have some expectations about what may happen, and that's sometimes dangerous. At the same time, it's good for some people when they can expect that, when we go through trauma, it's okay if we have insomnia, it's okay if we don't do everything perfectly. But for some people, these expectations become reality, that I expect that this will happen, so this will happen. I will have insomnia. I will have addiction, and actually, from the groups that I'm doing and from my colleagues, the substance abuse is not yet on the surface, but what's more on the surface is other type of dependence on sometimes binge watching things just to withdraw from or distract from what's going on. Eating, I hear a lot about binge eating and the emotional and stress relief eating that's happening a lot. So that's not.
I was joking with my wife. It seems like every meal we're having now, it's like almost the last meal. We're afraid that this is the, and from my work with cancer patients, especially young who feel like unjustified suddenly being a victim of terminal illness in such young age, they become compulsive shoppers. They become, compulsive in their, boundaries in terms of relationships and stuff. They really lose boundaries and such. There is another thing I just want to ask you about the anger, like identifying in each other, because let's face it, we are health professionals, and traditionally, historically, we have an oath to really give and try to help, even with the risks and exposure and stuff. But in contemporary world, we are also reminded of our rights, and we should be complaining if things are not adequate and stuff. And we have mixed feelings about those two, aspects of the altruism, which actually is very helpful in a way as a defense in face of trauma. But at the same time that our families have rights from us, they are, expected not to get an infection from us or us dying suddenly when they don't even have income. We are the sole breadwinner. Then we think about our life, insurance and stuff like that. It's really, it's a tough time to catch risk from simple job as like just going to the hospital to see someone. You said something about the frontliners, that everyone is now a frontliner, patients and doctors, and the people in Target who are selling this stuff are actually frontliners. So we are all in it together, but at the same time, we feel the population, the general public hold us in such a high pedestal. I'm almost always amazed how much people think of me when I'm talking to them as if like, I'm something special when I don't feel that way. And those dynamic are very, very complex to handle, because our abilities, our mind abilities are much heavier than our, personal attributes in general. And that's one of the things that really make us stressed out all the time, almost in this disaster. And the survivor's guilt you mentioned.
Yeah, that's why expectations management is a big part of it, to manage our expectations. I think Maysoon, you have a comment?
I don't know.
Go ahead.
Am I still mute or am I on?
We can hear you.
You're on.
Yeah, okay.
Go ahead. Maysoon is an internist in California, and she is the vice president of SAMS. Please proceed with your comment.
Yeah, hi everyone. So, so first of all, speaking of binge, eating or binge watching, Netflix got me now, so I've been binge watching.
Yes.
But other than that, I really have actually. My question is probably going to be more for Iyad, because he's been really involved with the Syrian trauma that we've all lived in the last 9 years now. So and in somehow this also connects to that trauma, because it is a global trauma. Now here we are, we haven't even come out of the Syrian trauma. It's been going on for such a long time, and we're very traumatized emotionally, physically, everything. And yet another thing hit, and it is this time not just my hometown, it is planet Earth. So there is really no escape. I can't go visit, another country. I can't travel. I can't have fun for a week here or a week there. In addition, of course, all the what's happening even here at home, not being able to be close to relatives, friends, everybody else. So all of us are in this together, as Iyad just mentioned. The question is, if you're to kind of look at this and with one word or one sentence that could be or could carry some relief, some way to distress, what would it be? Like at the end of the day, what would I tell myself? What kind of I'm not talking about practices like exercise and meditation and this and that. Of course, these are all important, but what is it, that concept that's going to keep me going? What do I tell myself? Okay, what is the next thing? Again, talking about
honestly, honestly,
yeah.
And honestly, the most strong in our culture, the strongest is لا يحمد على مكروه سواه. You might think this is really cliche, but actually this is, faith is very important. That's one. And the narrative behind it, what it means. What does this means as community? The other thing is you have to remember that we as Syrians, we had traditionally, especially the generation came from Syria and practicing here, we had very little trust in systems in general. We actually are almost paranoid about anything that comes from, systems or governments and stuff like that. And I think that actually played a little role in the initial phase of the disaster, like how to react and what to do. But faith is very important, and I think Dima was gonna talk a little bit about spirituality and mindfulness, which is the same thing, because at the end of the day, this is a natural disaster. This is not man-made. It depends heavily on behavior, on every single individual behavior. So you'll have to have in your heart the belief that the same way you're trying to protect yourself and your family, others are doing the same thing. You have to go with that faith that eventually we're going to come out of this even stronger. As Dima said, a little bit of anxiety and depression is actually not only normal, it might be an indication of good outcome. Because remember what Dima said, she said that those who initially have some anxiety and fear seem to be doing better with time. And that speaks to the learning aspect of trauma. When trauma happens acutely, suddenly, there is no chance to learn how to react. But when things are happening over time, if you have the capacity to actually learn, you actually get better after a few days, after a few weeks. There are those, and Dima had kind of hinted to that, there are those who have minimum capacity to tolerate this on, or they have no threshold, their threshold for learning from it is not as good as others. And those are more probably having more propensity for anxiety and depression. And those are the ones we need to point out to them. The young ones, the one who didn't have experience before, the ones with a temperament of anxiety and perfectionism and high expectations, and those who have a heightened sense of needing to control everything. But I don't know, Dima, if you have any specific about it.
So
the mindfulness and spirituality.
Actually, you mentioned two very important points, and the first one is not trusting the system, and that actually have been shown recently that most of the general population, especially in the United States, they don't trust the system to protect them, and it's more in minorities and more in immigrants, but
yes.
In the general population. Actually, gun sales tripled during the last month.
Yeah.
And that's because people people shouldn't be worried about the system protecting them. They shouldn't be worried about having enough supplies. But because of this lack of trust, people actually go back to their religion, to their tribe, to their families. And that's what protects us as a community, actually. That's what protects us, what we believe in and what we belong to, because that's where things become more real for us. And that's where we don't have to put a lot of false expectations on. We know that family and our religion, our beliefs, our culture is there, and we know that we belong there. And that's where most people actually, that's why we saw a lot of religious gatherings that they refuse to cancel. That's not just because they don't want to cancel, but because a lot of people, they don't trust the system. They trust what's in there, what we believe in, what we belong to. And yes. And there have been too many studies that show that religious belief and spiritual practices do help. And it's not just a touchy feeling or a cliche thing to say, but it is. They do actually help in going through the trauma. And acceptance, just acceptance and surrendering to what's going on. It's beyond our control. It's above all of us, and just surrendering and just being in, maybe it's hard to be in peace, but just accept that it is going on. And if we have this belief, then the religious belief actually do protect people. Because we live for the hope of the afterlife. We live for the hope of something bigger. We do belong to something bigger. We do belong to a bigger community. We do belong to a bigger entity, and we should accept what is beyond our human control. This is really, who expected that this will happen? No one imagined 3 or 4 months ago that the whole planet will be staying home, not interacting, and just fearful of death and fearful of this infection. This is beyond human.
Yeah. To go back to Maysoon's point and the idea of, as a community, like we're burned out, so to speak, with a previous disaster, but that was man-made. We have a clear, identity or clear entity to blame. With this one, it's really beyond, it's a naturally, the response is completely different. And the one has to resort to at some level of faith, where there are things that, as our saying that everything has a meaning, even bad things has some sort of meaning. But that sometimes it's very hard to keep that in mind. Another thing is to keep a good narrative of some kind, like a social cause or a role, and keep in mind that if we're not merciful to those who are around us, we cannot have the disaster as an excuse for lashing out and not being merciful. We have to actively remind ourselves to be kind, and it's almost always possible to be kind to ourselves and to others.
So I want to also see if the audience, if somebody want to participate in a question, either by writing in the chat, or he wants to talk for 30 seconds and ask a question or give a comment, please do so. We have Dr. Iyad Khouri and Dr. Arbash both available with us right now. So please, if you want to participate, raise your hand or put in the chat. Now, until we get this from the audience, Dima, there was this, I like the one about recovery. When you show the line with recovery. Let's see here if somebody was trying to raise their hand.
I think I do have a question.
So yeah, this is, would like to know the factors that kind of help this group. They do have this initial moderate response that he said initially you're gonna have this anxiety and depression normal, and then with time you go into recovery. But I'm kind of worried about these delayed and the chronic, that we be part of them. How can we be part of this line?
So
this is
as
the
you
faith
can see,
that we talked about, the faith, the help, identifying, the expectation, everything you mentioned that put us on this line.
So as you can see from this graph, the people who went through recovery, they went through sometimes up to severe anxiety and severe symptoms at the beginning, and that happened, but they went through it. And what this specific study showed is family and social support were the two main factors, and having and working actually in more organized system rather than less organized system. Actually, the nurses who worked in the ICU showed faster recovery than the nurses who worked in the regular floor, because they were more prepared, they had more expectations for what's going to happen, and they did see the most severe cases. So that's about it.
And they survived it.
Yeah, and they survived.
Yeah. So actually, they might even become more callous, in the future. They might, that's the learning aspect of trauma.
That's the learning aspect of trauma.
Of course.
Yeah, exactly.
Trauma is fear, and fear always gets better with more exposure. Always.
The second point, which came from our presentation, I work as an educator also in our residency program. And I'm really concerned about the residents. And right now, from your talk, is they're being thrown more because they're young. They are the least effective. Even if they get COVID, they will be fine. So there are in every single COVID unit, you will see a resident. And I'm very concerned is programs should be actually preparing their residents, not during, but even after residency, what they should plan for their residents when these cases. In our hospital, it's different, because in our hospital now 55% of the inpatient are COVID positive. So some hospitals may not have this. We are in the suburbs of Detroit. So I think that group of residents who are right now thrown in that mix, we should have a plan in our program what to do with these residents when these numbers goes down, so that trauma does not affect their life or affect should we give them more time off? Is that something we have to give more electives? Should we, I hope if there is a study or some guidelines that we can.
So the ACGME actually published some guidelines that were about what to do within the residency, and their guidelines basically is to be more protective for residents and for young doctors, because it will affect them more. And what we are doing in our own residency is we're trying to do as much telemedicine as possible. There was a study actually that I was between putting it or not, because it's about more team management, and I wasn't sure how many of the audience will be interested in more team management rather than personnel management. But this study is about how to manage your team during I can send you the link actually.
Because you have to remember also, Dima, if I may say, that young people also they have extraordinary sense of invincibility. They also are more adventurers and more, from working with children and adolescents, that's actually get them more into being driven. There are also a couple of medical schools right now. I know Harvard for sure are graduating the fourth year medical students like this month, so they can start the residency earlier, skip the electives, few months. And they're doing that. So it's a very complex, because again, it speaks to the conflict of duty in us. We went to medicine not because we're afraid of death or anything. We just this is,
yes. So this is your question about any studies or any data about how to manage your team. So basically, and this is during the Corona pandemic, it's basically what they're saying is you have to be clear with your team, and you have to tell them what's going on, not give fake hopes or fake safety, and you have to lay the expectations, and the supervisor or the manager need to be the person who take the responsibility of delivering the information, but also knowing that they are also human, and the team cannot expect them to do everything or to know everything. So being honest about not knowing what's going to happen or not knowing what's next is a good strategy, and it's shown to be effective. Actually, what too many programs are doing is short update meetings with their residents, where they meet every few days or every week for 10-15 minutes with the administration, and they just get updates on what's going on and what are the changes in the plan and what's going to happen, because things are changing very quickly. And for some residents, they don't know what to do, and sometimes the administration, they don't know what to do. Even the ACGME, for some time they were sending like different messages, and at the beginning they didn't want residents to be exposed to patients with COVID-19. Then they said it is okay to be exposed, and so being honest with the residents and being somehow protective, knowing that they are more at danger of psychological stress, and later on reflect on what happened, what to learn from that, and how to be prepared for other traumas. So another thing that I do in the residency is I lead the Quality Improvement Council, and actually our quality improvement project now is to write mini resident-to-resident manuals about how to deal with telepsychiatry, how to deal with the telemedicine, how to deal with this crisis, and just a guide for, first of all, for now, and then we never know what's going to happen in the future. So we are documenting everything we learn. We ask the residents to do that because it's from their experience, their perception of things, and we're going to try to learn from it and then guide the coming residents about that.
So Dima, I think we have a question here from, I believe it's from Dr. Maher Azzouz. And before I go on to his question, I'd like to comment a quick thing. When you said that the ICU nurses are actually, kind of handle it better, I do remember myself the first day when we switched to telemedicine. From I do primary care mainly, so when we switched to that, it drove me crazy. I was really anxious and not uncertain about a lot of things that I went to my colleagues, and I said, just put me in the ICU. I'd rather be working with a COVID patient than it is to kind of not know what I'm dealing with here and just doing phone and not knowing who to test and this and that. So it is correct that it does give you some certain facts and certain kind of expectations. So, but going to Dr. Maher Azzouz, I think it is how do we talk to our family about risk? How do I address their fear of as a healthcare provider transmitting the disease to my family?
So I'll talk a little bit and then I'll leave the child part for Iyad because he's the expert in child psychiatry. So actually it's the same concept as what to do with your team and with your residents. First of all, be honest, especially with your spouse or whoever live in the house with you, your parents, the rest of your family, the children who are at the age that they can understand what's going on. Be honest that frankly, there are too many things that I don't know. We are trying our best. We will try not to get, I will try not to get infected. I will do everything that is in the guidelines, but I don't know. I am not sure. And we are in this together. It's scary, and it's scary for the person and for their family at the same time. Sometimes reassuring the person that like too many people of my team are exposed the same way I am. So we have this shared experience, and they have families too, and their families, they're having the exact shared experience as we are having. So we are not in this alone. It's not because of us, and it's not just our problem. I know sometimes this doesn't help. So what if it's not just our problem? And we're still scared, we're still worried, and that's okay. That will happen. We will be worried, but the important thing is that we are in this together, and then we will try our best. There is no guarantee that the person who's coming from the hospital will not get infected or will not bring the infection home.
I had this issue actually, Dima, with my parents. They're both elderly. They live close to me in a separate house. They're 89 and 84. So how to tell them when I'm rounding in the hospital, when 50% of the inpatient are COVID, maybe it's the good time not to meet in person and meet over FaceTime. And it is a difficult, but I think that communication with them, the risk and how it's better, because initially they felt that's like almost I'm abandoning them, but actually I'm doing it for their benefit. But later on, we kind of limiting it. And when I go in with a mask, and I think the communication with them, they understood it. Now, maybe a week or two until things get better in the hospital, it's a good time. But it took me a while. I was worried about their mental health. If I don't visit them, you know, more than they, you know, they might get sick if I go and visit them. So it's kind of took a lot of discussion and communication to make sure we reach that point. They're comfortable and uncomfortable to minimize the risk and continue to visit. So I think a lot of people going through this in different level, it depends.
And sometimes it doesn't happen. For example, my mom still insists on visiting me. My husband did get sick and he was in quarantine for 14 days. And my mom did insist on come and visit. And she's 76 and she's a breast cancer survivor. So I am worried that, and I did my best. I explained to her, I told her stories. We lost one, the husband of one of my husband's cousins. He died in New York because of the pandemic, and he's 60 years old, so he's very young. And I explained to her, this happens, this can happen to us. And she still insists. It's something that we have as healthcare providers, that we are responsible for everyone emotional and physical well-being. And as much as we want to believe we are, we cannot be responsible for everyone's well-being. We want to, we would love to, but sometimes we do our best, and then things will happen, and it's not our fault if it happens. It's hard, it's not easy to come to peace with this, but sometimes it's just happen. What can we do? It's our own sanity sometimes, that we cannot control everything.
Do we have any other from the audience want to?
It seems like there is actually
Can we
from
unmute?
Dima. Yeah, hi Dima, Dima Lababidi. So there is also extra stress for physicians who work in leadership since responsibilities have increased tremendously.
Right.
And yeah,
Yeah, another comment is about the expectation. Especially some of the healthcare workers have more a structured life or structured schedule. And now with this uncertainty, there's always moving, you know, about meetings or changing policies. Sometimes every other day or every day, the policy change in offices, in the hospital, in the staff, in the meetings, seeing patient, telemedicine, no inpatient, no, you have to go. So these keep changing, actually add to the stress. And one of the audience kind of pointing to this is an extra thing that adding to the stresses.
Yeah, that's very important. Actually, managing expectations is very important because we have very high expectations for ourselves and for our families, and we expect that this will continue as we go through this, and it cannot continue. Things cannot continue the way they used to be, and things may not go the way we want them to go. It's okay if things do not go on everything under our control. We can actually, a good tip that I give to people in the support group is that we can list things that are under our control and things that are totally not under our control, and things that may be under our control, but it's okay if they slip out sometimes. Like, for example, minimal things like I don't want my kids to watch TV for hours a day. That's under my control, but sometimes it doesn't happen. Is that a disaster? I mean, I don't want it to happen, but it happens. It is an ongoing trauma, and I am going through it. My family is going through it, and it's okay if everything is not under our control. I can control my reactions more. I can control other things, but I mean, it's okay.
So Dima, Maher Azuz have another question. Said some providers elected to find other residents during this period if they're having exposure to COVID. But at the same time, would that increase the like the stress in the family, like abandonment of your kids and wife? What's your opinion on it?
So that's something that also I encountered, and actually it depends a lot on the other side, on the spouse or the partner, because sometimes if they are very supportive of you being outside the house and there is this teamwork, it's a little bit easier, but we as healthcare workers, we still feel that we need to be with our families, that we need to protect everyone. And it does add some extra stress, but having more mutual planning will help the person themselves to be more in peace with the plan they developed. But sometimes the family will put more pressure. And I would say what's going on now is that a lot of the providers have to do this against the wish of their partners or their family. And this is becoming more, this put a lot of stress on them. So more discussion, more explanation, and sometimes just accepting that we are doing this out of duty to our family, and it will pass and we can learn from it.
Irene Navis want to share with us, she said there's resources to help healthcare providers, children and families in response to COVID-19, rap-em.org. So she'd like to share that with us. Also, we have a request for sharing copies of the PowerPoint. This presentation will be, my understanding, recorded. And if you know, Dima wants to have a PDF of this file to people who registered, we can email them if you want. We can have a copy or PDF if Dima is okay with that. We can share
Actually,
with the rest.
yeah, so this last slide is some resources for physicians to help going through this pandemic. Some of them are support lines, and some of them are meditation applications. So too many applications are now offering free subscriptions to healthcare workers, and meditation actually help. I am like one of the people who used to see yoga and meditation as this boring thing, but it does help, especially now. So if you are willing to do meditation, there are few applications who are offering free subscription. Physical activity also help, we all know that. So there are, Peloton actually is offering 90 days instead of 14 days for their membership, and other sites are offering free subscription, and there are some educational tools also. So so this is the last, the before last slide, about resources that physician can use to help going through this pandemic.
The question also, the financial instability, which is really, this is something, it's hard. That was mentioned by Dima Lababidi about there always that increased risk during this pandemic. Dr. Firas mentioned the survey seems wants to have, that's interesting. Yeah, we have a survey we'd like to answer, but number one did not have an option for no problem. Just pick, unfortunately, I don't know why the survey did not have not applicable, but to submit, you have to pick something. Maybe just put one of the confusion that maybe, I don't know, registration process. That's stressful. The yeah, go ahead.
So the financial risk, you mentioned that, and that's something that does come up. And I think the thing that helps the most is understanding limitation, that there are limitations and what's going on is unfortunate, and it's out of what we planned for our financial and professional career, but there are limitations to what we can do, and asking for help, actually not for financial help, but for resources, because there are too many resources now that people do not know about. So asking colleagues, going to websites and asking about ways to recruit some support, financial support and financial help will help the person, first of all, be less stressed, because they will know that other people are going through the same thing, other people who, let's say, own their businesses, or they are contractors, they are going through the same thing. And what are they doing? What can we do? And what are the support resources that people can use?
All right, so there is also comments about the integrative healthcare online course, that part of it, Dima Lababidi mentioned that she learned about taking care of yourself and practice self-reduction and yoga that sometimes help. So I think everybody, sometimes we find it in faith and yoga and treks, playing cards, online. We just have to find things that support and give us a change of mind, but at the same time will not completely take us off reality.
And self-compassion actually is very important. I mean, at the end of the day, we have ourselves and we have our minds, and we need to deal with that. And some advice that sometimes I give is, when you feel the most stressed and the most guilt and a lot of difficulties, imagine that you are your own child or your own sibling or your own best friend. How would you talk to them? What would you tell them? Sometimes I advise people to talk to themselves with their first names. Like, what would Dima do now? What should Dima do now? Rather than what should I do now? What should Dima do now? What do you think Dima is going through? Sometimes this will give you this non-identification with what's going on, that it is not because of you and it is not you. it's something that you are going through.
Yeah, never mix between the role we are assigned by society or by education and stuff and us as individuals. Our roles are big and huge, but we are limited. We're just individuals. You know, financial disasters, we have a whole country with trillions of dollars and they don't know how to deal with it. Let aside a practice somewhere where we have 5 employees or 10 employees. How are we going to do that? There is no way. We have to have faith that the social response somehow is going to fall into place. We have to. And not to focus on the idea that since I'm a doctor and I saved many lives and I worked in the medical field and people rely on me, that somehow I'm some sort of a god or close to a god. We are not. We're just, we're very, very limited. But at the same time, we're worthy of respect, our self-respect. We've done so many work, despite right now the crisis and stuff. Most of us, all of us, as individuals or doctors, had done tons of good deeds. And this is not going to take them away. And, you know, I'm talking about the financial stress of others who work for us and stuff, and we have to lay them off. Or, this is not going to be taken away because of that, because it's not neither intentional nor beyond individual control. At the end of the day, we're just, we have a role that is much bigger than us to begin with. And self-compassion is extremely important. You know, someone asked about how to deal with the families or what to tell the families in terms of children. If you have a child, you know from dealing with them, they have anxious temperament. You don't have to overwhelm them with too much details about what's going on. But in general, actually, kids are very proud of their, you know, parents who are working in health professionals. They're, you won't believe the amount of information they have. They have a lot of knowledge. And I usually approach them by asking them a question rather than telling them. I try to understand what their understanding of what's going on. And you'll be shocked to hear how much insight they have and how much pride they have in what you're doing. There are those who are the kids who have anxious temperament, and those are worthy of actually, you know, if I may say, even consult, like if they have a therapist already, or you trust someone like a family therapist and stuff, to you really ask them how to address them, because there is a way how to address anxiety, and it depends on the developmental phase they are in. So for those, again, going back to Dima's point about vulnerable population, vulnerable individuals in trauma, because overall the response to trauma is actually positive. In general, we learn a lot from it. You know, as Dalai Lama said, there is rarely any event that can be seen as negative from all point of view. There is no event like that in the world. But for some vulnerable population, particularly those who are, you know, perfectionists or have tendency for control or anxiety, they need extra attention and they need a little bit more focus, including spouses and children. And it's always a good idea to actually externalize the fear, you know, like for little kids before age 6, to, you know, have them draw what's the coronavirus, have they heard about it, what do they think, and draw their fear, and so they can come up with expression. For those who are in school age, they're actually very knowledgeable and they know what's going on. Teenagers, you know, they're teenagers. It's a tough game anyway, regardless of what their temperament is. That's just general advice.
Any more questions from the audience before we conclude the program in 2 minutes? See if there is anything else or anybody want to participate, please let us know. All right, so I think there's 2 new messages here. You got a lot of Iyad and Dima. Thanks for the your help and participation in this. This is we are happy to have you. Would like to continue with our SAMS webinar educational programs for healthcare workers. We're gonna be more coming soon. Please, when you get our emails and interested, please join us. Again, I would like to thank Dima Arbash for her participation, and Dr. Iyad Al-Khouri. Was so very nice of you. Maysoon Hariri, the vice chairman, the vice president of SAMS. And I would like to thank again Shadi Al-Rayes, our digital moderator. He's amazing. He's a cardiologist who helping us in all of these webinars. Our staff, Talia and Ala, thank you very much, everybody, for coming. And good night.
Thank you.